gonna have this last session about complications. And then, I recommend just to stay because we will discuss about the research proposals. So it's just only 2 sessions to go. And we'll start with the first presentation by Alexander Sedaghat, talking about pericardial effusion prevention.
So thank you very much, Adel. Thank you very much, Xavier. Great thank you and all of you for the possibility to speak among so many friends and colleagues and experts in this field. I'm pericardial effusion prevention. I thought it was actually not so easy topic to grasp. So first thing I did is ask ChatGPT on what I should answer. The good thing is it came out to be the same, that the structure of things that I was going to say anyway in my presentation. These are my conflicts of interest. So prevention, obviously, as Benjamin Franklin said so well, is worth a pound of cure. So prevention actually, especially in the field of left atrial appendage occlusion of complications, is key. We have a procedure which is more or less prophylactic and prognostic. We want to save patients from bleeding and save them or from stroke. So we have to be absolutely safe in our procedures and have to prevent any complication as possible. So if we talk about pericardial effusion, obviously, I guess there's nobody in this auditorium who's not seen pericardial effusion or tamponade in the context of left atrial appendage occlusion, but the incidences are very low. This is a analysis compounding a lot of studies on this field, and what they conclude is that the range is basically in the clinical context among all devices roughly between 1% and 2%, and this is for all pericardial effusions requiring intervention. So this is actually a very rare complication, yet, however, it has detrimental impact. This is data by colleagues Price and other American investigators from that former mentioned NDCR registry, and they see an incidence of pericardial effusion requiring intervention of about 1%. However, this is severely linked to dismal outcome. So if patients have such pericardial effusion, their outcome is severely impaired. They have a high risk of acute death and death also in the 45-day follow-up. So we have to do everything to prevent pericardial effusion. If we look at the literature, what are predictors of pericardial effusion? If we talk about preventing something, obviously we should know and identify what are risk factors. And it seems to be that, two things are of utmost importance. One is the fact that patients, if they come into the procedure in sinus rhythm, this seems to be a risk factor. Also paroxysmal atrial fibrillation, which I guess is somewhat the same risk factor as being in sinus rhythm and might be a surrogate of smaller, more hypercontractile left atria, is a risk factor. So change in this data by Price, they have identified that, and this was also previously shown in a study from a Chinese working group, the paroxysmal AFib, and change into sinus rhythm procedurally are risk factors. And also, and I think this might be due to anatomical differences, female sex, in addition to age, seem to be risk factors. So these patients presented a higher risk for pericardial effusion, and we should keep that in mind when we treat them with left atrial appendage occlusion. What other factors play a role? This was actually not what I thought it was when I looked into this presentation. The title was Prevention and Treatment of Pericardial Tamponade, and this was an EP registry by colleagues from Frankfurt, and they basically did a survey on what peer procedural factors or precautions were taken, and this is something that I would just like to highlight and show to you, that obviously it reflects, I think, also the reality in the interventional cardiology forum, if you will, that guidance of transeptal puncture, which is one of the key issues or contextual parts of the procedure potentially causing pericardial effusion, is guided in a great variety, either be it fluoroscopically only or guided by TOE, which for our center at least, and I think with all of you, is a standard of care, or by ICE, or even by other measures. In this context of imaging, I think it's worth to say or to mention that it might even be, although I know there are a lot of proponents and esteemed experts in eyes, it seems to be that eyes could, at least in the hands of maybe less experienced cardiologists, have an increased risk of pericardial effusion. On the left side, data by Al-Khoury and colleagues published 4 years ago, where in their monocentric experience, there was no difference between eyes and TOE-guided patients during left atrial appendage occlusion regarding pericardial effusion. However, if we have a larger, broader spectrum of interventionalists in the NCDR registry, there seems to be a trend towards more pericardial effusion, which might be attributed to the more invasive context of that imaging technique. Regarding the prevention of PE, I think there is some music in the field also of better planning procedures. This is data, obviously, you know, the study by Joëlle and Philippe, which has effectively assessed the influence of pre-procedural planning via CT and computational modeling on left atrial appendage occlusion. In this specific study, pericardial effusions were very rare in both groups, comparable, and we did not see a relevant difference. However, those were only 200 patients treated in very experienced hands with a lot of experience in left atrial appendage occlusion in general. So I guess if you take that issue to a broader non-experienced spectrum of interventionalists, I think there will be a signal towards better safety when applying these techniques. As for my own bucket list, if you will, of things to do, how to prevent PV, there's actually, to my knowledge, not one single thing that you can not do or do to prevent PE. So I sort of summarize what I would suggest to be relevant in this context, and I think it comes to basically 4 fields. One, and the first and most important in my opinion, is patient characteristics, so that you need to identify a high-risk patient, which also plays to the field that I think personally you should know a lot about the patients before putting him into the cath lab or before he undergoes the procedure. You should know whether he is a high-risk patient regarding his rhythm. Gender obviously is evident in most cases. Before the case, you should rule out PE. I think there's not anything worse than during the procedure having like this small rim around the left atrial appendage, and you're not sure if it was there before. So always do imaging at the start of your procedure and document that, so your echo guy will not be shaking when he needs to reconfirm or talk to you about the PE which occurred during the procedure. Obviously, hemodynamics play a big role, even especially in non-experienced hands. I think that, and I guess there's also a big discrepancy or spectrum here on how you guys use it. I've seen several cases with a pigtail in the aorta, and several cases without. I guess some more lean LAA experts tend to be less invasive. Don't put arterial lines. I think personally an arterial line, especially in radiology, is helpful not only for assessing hemodynamics, but also in expected difficult cases of transeptal puncture to even put a pigtail into the left and into the aorta. And in case of air embolism or whatever, you have your access also to aspirate if there's air in the aorta. Measurement of LA pressure, I think, is an issue which needs to be taken into account, that LA pressure should be, especially in those patients with small atria and sinus rhythm, should be as high as possible. So fluid challenge is relevant. And regarding transeptal puncture, obviously, you should have your device at hand, or your technique that you are most accustomed to and that you master the best, and you should avoid multiple punctures, which also, again, depends on how you plan the position and what the aspects you know about the orientation of the LAA. So I personally think you should be aware of the best access, or should at least think about the best access towards this specific LAA you're challenged with during a procedure. You should know how to manage the difficult septums. Louis had this excellent talk on how to do that, so you should be able to manage without a difficult septum without repuncturing it. if possible, obviously, placement of an aortic wire or pigtail, and the timing of heparin, I think also during transeptal puncture could be an issue, and I don't know if there's any data on that, and what your feeling is would be interesting to me is when do you actually give heparin during the procedure? Do you give 50% of your heparin dose before or during or at the beginning of the procedure, or half after transeptal puncture, which is done in some centers that I've seen. So that would be possibly a factor influencing that. Regarding the positioning of the delivery sheath, I think there is, for me personally, the most relevant part is that you should not compromise on the imaging. Whatever your technique is of imaging, be it fluoro, be it TOE, be it ICE, or CT beforehand, or whatever it is, you should be confident to see the LAA as you wish to see it. I remember one specific case of, I think it was even fatal, pericardial effusion, where we were hesitative to use contrast because of renal failure. It was a patient with diabetes for several years, young patient, and I think we perforated the LAA, and we had no means of helping him recover despite ECMO and all of that. So I think you should never compromise. No, 5 milliliters of contrast will not harm an already insufficient renal patient. I think you should always try and go for the best imaging, whatever that is to your understanding. Always try not to change the delivery sheath via the LAA. I know if Horst Sievert would be here, he would be of different approach, but I think you should always try and change your delivery sheath over the stiff via using the pulmonary veins, which is, I think, less traumatic, and I guess you would all agree that. And personally, I also use a pigtail as a fender in the delivery sheath. Some centers do not do that. I would not recommend that if you want to prevent your PEs or reduce your PE numbers even to less than 1% in the procedure. Regarding device delivery and repositioning, obviously you should be sure about your sizing, which comes again to the fact that you need to be planning. Obviously resizing and manipulation are risk factors, known risk factors for PE, which should be prevented. And obviously you should know your device. You should know how the mechanics of anchoring work with your device, if it's traumatic or less traumatic. I guess there are some cases where you should be using a less traumatic LAA when you have an LAA occluder device. If you have a LAA where you're expecting to be encountering issues, you should maybe in this specific case then use, for example, a Watchman Flex rather than a more traumatic device, although I guess there is no data on that. And you should always know how to retrieve your left atrial appendage occluder, because in case you have embolization or whatever issue, you should know how to get that and obviously have the techniques at hand. So with that, I would like to conclude my very fast talk to you guys. Thanks for your attention. And obviously, prevention is still better than a cure, especially with pericardial effusion. Thank you.
So I think that we should move to the next speaker, and then we can discuss. Maybe we can stop after this second and talk about pericardial effusion. We'll see.
What the audience want? Discussion at the end, or after pericardial effusion and before embolization? What do you want? After?
Okay.
Okay.
Okay, so Christoph Hammerstingl will talk about the treatment of pericardial effusion.
Yes, thank you very much. And of course, I'm in line with Alex. Prevention is better than to treat it, but my task is to summarize what we know about treatment tools and techniques if we have pericardial effusion. Alexander already pointed out that there is some incidence, and it decreases in very experienced centers, which means that there might be some measures that can be undertaken to reduce it in terms of prevention. In very experienced centers, the incidence is below 1%, and please be aware that 50% of pericardial effusions occur not immediately during the procedure, but after the procedure. So we have to look at the patients after follow-up, and of course, as what Alex already pointed out, it has an impact on outcomes, so we have to deal with it and we have to avoid it, because those patients with worse outcomes, of course, have been treated. So I think we deal with some, I would say, with a really bad complication. How to diagnose, of course, we have to be aware that there is an acute hemodynamic impact, which can be nicely seen with echo. If we see such a huge pericardial effusion acutely, what you see on the right-hand image, then I would say it's clear that it needs urgent treatment, and it's very important to know what caused this effusion, because if it's just a transeptal puncture, it's a bad situation. If it's a perforation of the appendage, it's a very, very bad situation. I would say that you cannot treat only by pericardiocentesis, but you have to call your surgeon immediately, and you can try to stabilize it. There was an consensus group or a working group from the European, from the ELAACC on how to manage pericardial effusion, but on the long term in patients with chronic diseases. But I would say if we face an acute tamponade in the cath lab, we must immediately prepare for treatment. So I would never advise to wait for minutes and then start to prepare everything that is needed for pericardiocentesis. It's very important from my point of view to have everything available to be prepared for treatment, because it's a very severe situation. So how is it done in daily practice, in daily routine? There's registry or retrospective data, collected data, how it is done, and because there's no clear standardization, then it's left to the single center experiences with is traditioned from doctor, from physician to physician, which means that there are a lot of treatment, I would say, ways how to do it. And when I read this paper, I was wondering that only 60% of the centers using echo for pericardial puncture, and every center, of course, uses fluoroscopy, but echo is only in the cath lab in 60% of patients needing pericardiocentesis. Most of the effusions are drained by use of a pigtail, only in 80% of cases with a sheath. The need or the use how to give protamine or antidotes, it's really not clear. It's used in only 85% of all cases, and one half give it immediately when pericardial effusion occurs. The other half, you can see it here, give it after it has been drained. I think the rationale behind this is that to avoid clotting of the blood within the pericardium. We can discuss about this. The use of autotransfusion during the treatment course is still a matter of debate, and the decision when and how to contact the surgeon during this whole process is still unclear. But from the working group, the ELAACC, on how to do it, there's a clear statement that we should use echo-guided puncture first. And there's a clear statement that you should, and of course, if we do LAA closure, we have an echo machine in the cath lab, and you should use an echo-guided puncture. And this is an example how you can make sure that you are within the pericardial space by the use of agitated saline, which is somehow a contrast dye, and of course with fluoroscopy to make sure that you are entering the pericardium, that you are then in the pericardial sac with the needle and the wire, and then you can, they are not moving the images, and then you can enter it with a sheath and the pigtail. This is what I always do. I use a sheath to stabilize it, because the pigtail sometimes it just you enfold it, and then it makes the whole procedure very embarrassing. So I use a sheath, and over the sheath I use a pigtail. Now they are running, okay. What I've already talked about, there are many uncertainties when and how to call the cardiac surgeons, and even the need for invasive blood measurement is still is not in every case. They have an invasive blood measurement, and even the topic if a patient is stabilized, when it's feasible to remove the drain is not really clear. This is a smaller study stating that if it occurs during a pulmonary vein isolation, then it might be feasible to remove it early. But from this registry, they advise to leave it at least for 24 hours. But there's no clear, I would say, no evidence that you might decrease or increase any risks by leaving it for 24 hours or by removing it earlier. But you can think about this, and the usefulness of direct autotransfusion might be helpful to stabilize patients with a massive pericardial effusion and to buy time for patients to ultimately undergo surgical repair. This might be helpful, and we should think about to advise to have it at least in your hospital, to have it available in such a severe situation. I don't know it because there are no clear data that it really impacts on outcomes. Like, for example, an impeller, nobody knows if it really impacts on outcome, but you can have an acute stabilization, but you don't know if it really impacts on long-term outcomes, and those are the topics we have to discuss once again. I think we should not discuss what should be the default strategy, that you have an echo in your cath lab and then you should use it. But what is matter of debate is when to apply an antidotes and before drainage, after it has been drained, when it's feasible to remove the pericardial drain. The usefulness of autotransfusion is matter of debate, and clear criteria when to call the surgeons in the room immediately if it occurs. If you think about that, it's a perforation of the left atrial appendage and so on. And yeah, I think there's a lot of work to do, and I thank you for your attention.
Thank you. Maybe you can come here and then Alex, well, for the discussion if you wanna. Yeah. So let's move to device embolization and talk about same structure, prevention and treatment. So the prevention part is gonna be done by Dr. Rodrigo Estevez. Thank you.
Thank you, Xavi. Thank you for the invitation. So we'll talk a little bit on how to prevent device embolization. So usually this complication occurs in the setting of malpositioning during the procedure or inappropriate sizing, which is a major issue. It's not very common. It's been from 0% in the pinnacle flex with the new devices to 1% in the early studies across the range of different devices. Of course, morphology of the LAAC can play a role. We have discussed here about the classification, anatomy, and we acknowledge that some morphologies are much more complicated to treat, to calculate the sizing, and to perform the procedures, such the ones that are listed there. And therefore, procedural planning and team experience is essential to minimize this complication. So, of course, you already know there are many different types of LAA, and we have to make sure that the measurements we take for the sizing are correct, taking into consideration the type of devices that we normally use. In my experience, these are the 3 devices that I use in my cath lab, and of course, you know, there are some differences in the measurements we need to take the sizing. Of course, we have 2 main modalities for pre-planning. One is echocardiography. Now we acknowledge as well that 3D echocardiography should be a 3D imaging. Any of the imaging is essential, and of course we have the CT that gives you even more information. For the imaging, we know that we have to do the type of measurements we need both for amulet and for Watchman devices. But and I don't want to repeat myself, 3D evaluation of the LAA now, giving us the diameters, area, perimeter, is essential now to achieve a perfect result. That is what we have to achieve. Of course, CT in those centers that can use CT is also a fantastic tool to predict the type of device, to analyze completed anatomy and all the characteristics that we need for selection of device. And if you can use it pre-planning, that will give you a lot of information to avoid any type of complications. Of course, we have more advanced imaging, not only these 2 like basic analysis, but with special software we can do a full analysis and predict how is going to be our procedure, how we're going to do the transeptal and make this easier, both trimensio, or we can do the simulation with the FIOPs that has been already shown here. Using that and the prediction, we can decide type, size, position of the devices we use, and we already know that when we use this, our procedural success increases compared with only using standard planning. We have new softwares to pre-plan our procedures to make it successful and avoid embolization, such as Materialize, the Philips R Navigator, and in some cases, even special cases, probably super complex, we can do even 3D printing to assess how the device is going to set and to predict which size would be the best. Of course, every device has its own sizing charts. That's the one for Amulet that you already know. Special attention for those elliptical LAAs that we already discussed. You need to do a special sizing for these elliptical LAAs, and in case of this super elliptical, the size that you're going to use for your devices can change. There are some algorithms with different acronyms. For Amulet is the close that will give you all the ticks to deploy the device and to avoid embolization. In the Amulet, the load should be at least 2/3 distal to the circumflex. We need low compressions. We need the orientation in the axis of the LA neck. We need separation between the disc and lobe, and attention in the disc should be a concave disc position. For the Watchman Flex device, we know that we have more overlap in the sizes. We can compress more the device to select the sizing, and the acronym for the release and protect us against embolization is the PASS criteria. P is from position, should be distal to the circumflex, or at least 2/3 distal to the circumflex. Then we have the anchor that is mainly assessed by the TAC test, as you see here. We just pull back slightly the device and see that is attached to the LAA. Then we have the size that is measured by the compression in all the planes. It should be between 10 and 30%. Then we have the seal that we have to assess that there's no PBL or significant PBL around the device. And in case all these criteria are completed, we can deploy the device probably with very low risk of complications and embolization, as you see in this image. For the Lambre, it was explained before by Dr. Vaquerizo, we need our criteria that the umbrella is completely deployed with the UNs that are close to the radio pack marker. We need a distance between the umbrella and the disc should have a concave configuration. That means that we have enough sizing and tension, and we can safely release those devices. In this case, for example, if you analyze, just not paying attention to the echo, that you see that probably the umbrella is not contacting with the LAA wall, but you see that the umbrella is well deployed, the U ends are close to the marker, but there's no distance between the disc and the umbrella, and the disc is completely flat. It's a little bit like not concave. There's no tension between that. And if you have this and the operator didn't realize it, and you deploy this device, then you can have something like that, which is not very nice. But looking at the image, you realize that it didn't meet all the criteria for deploying those devices. So Dr. Vaquerizo said before she never seen an embolization of a Lambre, but we have seen. There's some of them. Again, in complex cases like this, that's similar to the one with the Fabian showed before. In these cases, we use a double Lambre technique, which means that you have to implant two devices. So in these complex LAAs, also embolization and dislocation is much more frequent. Like in this that you see in the right-hand side, you see that the inferior Lambre is completely dislodged and almost outside the LAA. So just to conclude, it's an uncommon complication. It depends on LAA type, and the planning and team experience is essential to avoid this complication. And if you have a complex case, then advanced imaging and even simulation could be advisable to decrease the number of these complications. Thank you.
Thank you very much, Rodrigo. I think, again, there's a lot of food for discussions after the last talk, so it's my pleasure to invite my Belgian colleague, Joëlle Kefer. It's the head of the invasive cardiology in Clinique Saint-Luc University Hospital in Brussels. She has done a lot of work to get the reimbursement of LA closure in Belgium, and she's very involved in the technique for many years. So Joëlle, please.
Thanks, Adel, and to the organizers for giving me the opportunity to give this very technical speech on treatment of device embolization. As you see, the incidence of device migration decreased over time with the experience of the teams, but it did not disappear, it still exists. And when you look at this first meta-analysis published by Adel on the first 30 cases reported of embolized device, you see that the methods for device retrieval were mainly percutaneous, but surgery was performed in approximately 1/3 of cases. The anatomical location of the dislodged device has an impact on the retrieval method. You see that all but one device migrated in the left ventricle need surgery, while it was the opposite for the devices dislodged in the aorta or left atrium, which were mainly retrieved using a percutaneous approach. And the size of the device matters as well. Device equal or greater than 25 millimeter were located usually in the LV or LA. So anatomical location of the embolized device has a huge clinical impact on the clinical outcome, general outcome of the patient, but also an impact on the management of the complication. We will start with the aortic embolization. Most of the time, this is asymptomatic. This is an incidental finding of a late migration, and it is retrieved by a percutaneous approach with a low risk for the patient. In case of left atrial embolization, usually it occurs during the procedure, but 1/3 can occur late. Symptoms could be arrhythmia, shortness of breath, and it could be retrieved by a percutaneous approach in the majority of cases with rare surgery required. But this is still a little bit complex than aortic recapture, and we can classify it as an intermediate risk situation. And the last anatomical position is the left ventricular embolization, which is a severe complication occurring in 2/3 of cases during the procedure itself, but could be diagnosed a little bit later. Usually it required surgery, but there is some space for percutaneous methods, and this is a high-risk situation. The in-hospital mortality is reported around 14%, but increased up to 20% among patients treated by surgery. Surgery is absolutely required in an emergent situation in case of device entangled in the mitral apparatus, especially with poor hemodynamics. But this means that in all other cases, we should do all we can do to recapture and retrieve the embolized device by a percutaneous approach. So material is key of success and should be available in the cath lab. You need large bore sheet, minimum 2 for French size larger than the delivery sheet you use for the LAA procedure, which means 14 to 24 French sheet. You need a snares, single loop or multiple loop. You need bioptome or vascular forceps, cardiac biopsy device, or raptor grasping device. This is a case occurring in my center in 2014. We placed an M-TTER cardiac plug 22 millimeter. It was a little bit complicated, requiring 4 recaptures for final positioning. You see that in the middle of the slide that the TUG test was acceptable, I guess. But the day after the procedure, the device was not in the heart, it was migrated in the abdominal aorta. The patient was totally asymptomatic. So we went to the femoral artery using a 14 French sheet. Using a cardiac biopsy forceps, we were able to grasp the end screw of the ACP, but when we reached the tip of the Mullins sheet, it was not possible to pull and collapse the device into the sheet. So we had to use a snare. We failed with the snare, with Gozenek. Finally, with an additional loop using an open 35 wire, it was possible to recapture the device from the patient. And after that, you have to obtain the femoral hemostasis. So for the aortic embolization, you need a large Borgia sheet, snares, bioptomes, and femoral closure devices. When you have to recapture a prosthesis, the design of the dislodged device has an impact as well. You should have in mind to pull the device in coaxial to the sheet, for sure, but you have to take into account the design of the prosthesis to retrieve. In case of M-TTER cardiac plug, this is the first generation, you have 2 end screws, the distal and the proximal. So the distal is the preferred snare point because the hooks are well positioned to retrieve the device into the sheet, but the proximal end screw is easier to grasp. For the amulet device is another story. As you know, the proximal end screw is recessed, mainly for a lower thrombogenicity of the device. So only the distal end screw is available for snaring. Regarding the Watchman, this is a little bit more challenging than the ACP amulet. For snaring, usually you need for larger sheets and snares. The threaded insert may be possible, but to snare, but usually it's too short and it's not possible to pull it into the sheet by this way. So you have to snare a few feet, the center of the device or from the sides. But you need usually a huge force, so don't hesitate to grasp it. You can use a cardiac biopsy forceps, but don't hesitate to use the Raptor device, which is an endoscopic grasping tool designed for gastrointestinal application. You can turn 360 degrees, so you can clamp the trabeculae of the device, and you can reach a coaxial alignment of the joist of the Raptor to the center of the Watchman disc. As it was illustrated in this case report of Wang et al. Last year, it was a combination of jaws of the Raptor grasping the Watchman device and the snare to retrieve everything from the patient. In case of atrial embolization, usually you have to go by the transeptal way to retrieve percutaneously the device. First thing to do for the safety is deliver a pigtail catheter across the mitral valve to prevent the occluder from crossing the mitral valve and traveling into the left ventricle. Here, this is a case of an ACP 20 millimeter dislodged in the left atrium. The operators used a 16 French sheet and extra backup sheet. A Gozenek snare 20 millimeter was able to capture the distal end screw of the ACP, and this was relatively simple retrieve into the 16 French sheet. This is another case reported by Turagam in 2020. This is a Watchman 24 millimeter device floating at the edge of the appendage. The operators would like to be prepared to the worst. So first they did a prophylactic pericardial puncture. Second, they prevent the stroke against embolic stroke using the WASP technique, Watchman in ascending aorta, for stroke prevention. A sentinel could be used as well. And third, they capture the device and they use a very large sheet from the transeptal way, 23 French sheet. A 12 French cat was advanced into the 23, and the Raptor device was rotated in a coaxial alignment, and its jaws was placed to the center of the Watchman disc, and it was possible to retrieve the Watchman by this way. In some cases, in atrial embolization, you have to use the double transeptal technique. So this is a case reported by the team of Ole, by Dr. Chopra. This is a trumpet-like large LAA treated with an amulet 31 millimeter in a deep position. In a couple of hours after a successful procedure, you can see that the amulet was swinging into the left atrium. The patient had prior mitral clip, which means that there is no way to go in the left ventricle or in the aorta. So the plan of the team was first stabilize the device. You see the hypermobile device into the left atrium. And then, after stabilization, try to retrieve it by the transeptal way. So first, they failed to stabilize the device using a gauze neck and a forceps. They use a 3-loops snare to push the device swinging against the lateral wall of the atrium with an Agilis catheter. And they were able to capture the end screw of the amulet, but they were with the Agilis and not with a big sheet, so it was not possible to collapse the amulet into the Agilis for sure. And they were able to recapture the amulet with the 3-loop snare through the septum, to the interatrial septum. For sure, there is a risk of damage of the septum, so you should be ready for pericardial puncture, you should be ready for ASD closure, but they had a very good result with no need for ASD implantation and no pericardial effusion, so it's rare, a little bit complex. You see that there is a second sheet placed here. This is a mitral clip catheter, 24 French. The plan was to use this sheet to retrieve the device, but finally it was the other one who works. But when they were in the inferior vena cava, they used a gauze neck and the mitral clip 24 French sheet to retrieve everything from the patient. In case of left ventricular embolization, the rule is surgery, especially when the device is entangled in the mitral apparatus. Urgent surgery is required. On the left part of the slide, you can see the left ventricular incision and the amulet recapture. On the right part of the slide, you see that some surgeons are more creative, and they propose to go from a transaortic way using a mediastinoscopy camera of 5 millimeters, so 5 millimeter incision in the ascending aorta. And under TE guidance, they were able to recapture the dislodged device from the left ventricle without left ventricular myocardial incision, which is probably the best for the patients, less invasive. But in case of left ventricular embolization, there is possible transfemoral percutaneous retrieval. You can use a pigtail to move the device through the LVOT, like illustrated in this case. This is an ACP 28 millimeter. So it was in the LVOT using a 14 French sheet, GR4, Gozenek. It was possible to recapture using a Gozenek in the aorta. There is a risk of aortic valve trauma, but if you pay attention to align the prosthesis during the recapture maneuver, it's possible to do it. And the last possible option is the transseptal percutaneous retrieval of the left ventricular cavity, like illustrated in this case, published by SAD a couple of years ago, using once again a very large sheet, 24 French mitral clip guide sheet, a pigtail retrograde from the aorta to stabilize the device far away from the mitral apparatus, and using a forceps, grasping forceps, Olympus, similar to the Raptor. So to conclude, device embolization is rare but could be a fatal complication. Anatomical location of the device has an impact on the management and on the outcome. Percutaneous approach is the rule for aortic and atrial embolization. Techniques of snaring and grasping should be adapted to the design of the device. Material is key of success. Emergent surgery should be done in case of device entangled in the mitral valve apparatus. And in case of this kind of complication, try to not to be alone, but try to work in a team approach. And this is my last slide. To suggest maybe a consensus on the device embolization treatment to discuss with every one of you, based on the anatomical location of the dislodged device in the aorta, in the left atrium, or in the left ventricle. And I stratified the strategy according to the access, the technique, and the risk. You see that for the aorta, mainly percutaneous, access is transfemoral, the technique is snare grasping, and the risk is low. In case of left atrium embolization, the access is transseptal mainly, rarely surgery. The technique is pigtail across the mitral valve and then snare and grasp with a single or double transseptal technique, and the risk is intermediate. And finally, if the dislodged device is in the left ventricle, you will use mainly a surgical technique by the left ventricle or the ascending aorta. In case of percutaneous approach, there is some space for that. You will go for the transseptal or transfemoral. The technique is left ventricle incision or aortic mediastinoscopy, snare grasping, and you are at a high-risk situation. So I am open to discuss that for sure.
Thank you. Okay, Apostles, I don't know if you want to join for the conclusions. Well, we can discuss. I have many questions, but I don't know the audience, you know, the club. So you have, or just, yeah.
I don't have slides. Just
Sure.
I just want to remind us, all of us, that there are some other complications, vascular complications, air embolism, and stroke. And since we are doing a preventive procedure, all these together might contribute to this 1% that we want to get lower. So these are the more important, but we should not forget the others.
So, Joëlle, I have one question that, well, so we're talking about big sheaths, but there are big sheaths that perform very badly, like the Cooks, that it can be like even a 20, but then when you try to recapture something, they invaginate. So from the industry standpoint, I think that it would be really interesting to make a formal recommendation. It's a 16 French, 80 centimeters, this brand, and then also just to make a formal recommendation for because I like the Raptor a lot. I think that the Raptor, it's amazing. And then you can spend a lot of time, like losing a lot of time with the goose snare and then snare, and then you end up with this, that it would be very easy. And so what's your opinion about like which sheath you recommend? Is there any specific, or just the rest of the group, any specific material that you would recommend?
But usually we use the sheet that we have in the cath lab, so you are right, 16 French in the 24 French in the mitral clip guide cath, which is not designed for device retrieval, the mitral clip device. And you are right, when you pull for a complete collapse of the device, you can damage the tip of the sheet, which is not designed for that job. So I agree for you that we need for maybe a deflectable sheet and with a very special tip to be able to recapture the device without damage of the cat, yeah.
So regarding the different devices for recapture, it seems I don't have a big experience with embolization because I had only one very long time ago. But when I look at people presenting cases, it seems that the Raptor is a very good device. So should we advise one device over another? I think it's easier to capture the device with the Raptor. The combination of the big sheet and the Raptor is probably the best to capture a device relatively quickly. If you don't have, I mean, if the device is floating in the left atrial cavity, you have few times before it will enter the ventricle, and then you really turn into a nightmare. So maybe, I don't know, we can, I don't know what the audience think about.
You are right, Adel, because if you can avoid surgery, I think you will save some life. Even there are some creative surgeons. So, and there are two different parts in this retrieval maneuver. First, to grasp, and for sure, the Raptor will help you to grasp very quickly. But when you have captured the device, the second difficult part is really to retrieve it. And sometimes with the snare, you capture the device, you pull, and then, it's lost. And you have repeat several times. This is really complex and dangerous. So I think the Raptor is really key in this maneuver.
So who has a Raptor in the lab? So we should, yeah, you have, okay, but because you have one embolization.
We had one, and we found out that the Raptor was the best.
And
yes.
Is there a big difference between a Raptor and a forceps? Is there a big difference between a Raptor and a biopsy forceps?
Yeah, it has much more force, the Raptor. The forceps, you can grasp it easily, but then, if you need to pull, you lose it.
You lose it, yeah.
And it's
because of
the
forceps,
same,
most of us have it readily available, but Raptor
But
doesn't have it.
for the industry, I think that maybe it can make sense, just to create, like an embolization package with a long, big sheath, stiff, and then a Raptor.
Which you can keep for 10 years before it
Maybe,
expires.
but well, I mean, it's okay, or it cannot be, or I don't know, they can move it from the city, I don't know, but it might be interesting.
Jens Erik?
Yeah, there's another device than a Raptor called Maraska that's also a grasping forceps. And the drawback of a bioptome is that it has very sharp edges, and if you grip into a nitinol mesh, you risk to have sharp edges from the nitinol. But what I find very useful for snaring devices is the use of a steerable sheath inside the large sheet. You can use an Oscore sheet and then use a gooseneck snare. And for instance, if it's an amulet, you can quite easily get very near to the screw end and then snare it. So a steerable sheath is a very, very good tool, I think.
Into a large sheet, yeah.
Yeah.
Very interesting. You want to? Exactly the same. Oh, we have already a consensus. No, great. So it's obvious that if it's in the ventricle, usually it's very difficult, especially if it's entrapped in the mitral valve apparatus. So regarding the pericardial effusion, what is disturbing is the late effusion. So and then it's difficult to see the mechanism, because if it's acute, you know that you had a difficult transeptal, or what? How if it's a late effusion, how can we differentiate a perforation of the appendage as compared to a transeptal? Do you have some clues, for example? For example, if it's like a venous, blood, like not super oxygenated. Sometimes it seems that you have puncture, for example, the right atrium, for example, or it was probably due to the transeptal. So probably just the drainage will help to fix the problem. If it's something that comes more at a higher volume, yeah, you can suspect that it's more like a perforation, and then you need to call the surgeon. Yeah.
No, I think there's one thing you need to consider before calling the surgeons, or at the same time at least, because You will, as the implanter, most of the time know, oh, this was really a difficult transeptal puncture, or I had a lot of manipulations inside the LAA. So you will know a little bit about where is the problem. And if the problem is perforation of the LAA, an advice can be to just finalize your LAA implantation, and that can stop the bleeding, and that can save lives, actually. So I have been in that situation twice, actually, not in my own lab, but it's very important that you call upon personnel and colleagues that can manage the pericardial effusion, and you as the implanter can have time to think again what is the underlying cause here, and if it's a tear in the wall of the LAA, consider just to finalize your LAA implantation. I know it's difficult because there's a lot of noise in the room and a lot of things are going on, but if you have help from good colleagues, you can actually create time to finalize your implant, and it can stop the bleeding in situations where it's peripheral in the LAA.
Great comment, yeah.
Jens Erik has just mentioned. I have 4 cases like that. One in my lab, 3 on the proctoring, but there was a clear pericardial effusion from the appendage. And out of 4 of these cases, 3 were resolved just by the quick implantation of Watchman device. 1 required, anyway, surgery. But 3 of these cases, bleeding was completely stopped after immediate implantation of the Watchman device, and then you are not so, let's say, precise that there is shoulder, no shoulder, just to put the device as quickly as possible, and it will resolve the problem, and it resolved, in my experience, in 75% of cases.
Adel, and you know about pericardial effusion, I wanted to ask Alex and Alexander about the pulmonary artery. This is something that we were just talking yesterday. Should we at least know it's dilated, it's close to the appendage? This is a relevant factor. It should change the way that we put the device?
To be honest, I have never encountered erosion of the pulmonary artery and left atrial appendage. I know there is accounts of that, so I would not qualify to give good advice on that. I think it again leads us to the way that we should know what the spatial relationship of everything is, which again leads us to the fact that we should do some sort of procedural planning to appreciate and acknowledge that there is a risk. Not sure if there is like a cutoff of dimensions or distance.
Yeah, well, there's not much data, but there are some case reports showing that it has occurred, and I think in Poland also there were a few. So I think I do 2 things. One is with the CT analysis, the landing zone is very close to an area that is less than 3 millimeters, very thin. I try to modify the technique and maybe do a sandwich technique, or implant a little deeper, so the hooks of amulet are not touching this area. I don't know if it works because, I mean, you never know, but we do that, and I sometimes also write in the CT report. And the second thing is that the implantation technique plays a role for amulet. When you deploy the device, especially a medium-sized device, and you do it quickly, there is this abrupt movement of the distal part of the device, like the cut nails, so the stabilizing wires might really traumatize the area, and then in combination with some contractility, maybe a tag test, you may create a trauma there. So slow deployment, very slow deployment is one, and the other is the, maybe modification a little of the depth.
Slow deployment, good advice.
About the protamine, usually we give protamine always at the end of the procedure. We check ACT and then we give heparin because it can avoid the dripping, late dripping of blood.
Yes, I think it's really important when you have pericardial tamponade first to try to remove all the blood in the pericardial space and then give protamine. And if not, there is a risk of acute thrombosis of the pericardial space, which is a disaster for the patient.
who gives protamine at the end of each procedure?
Yes,
procedure?
yes.
Everybody, routine?
Yes, we check before the ACT.
Only 2 people.
Over 200, usually we give 1 vial or half a vial of protamine. All the cases, yes.
So who does, Adel, you? So only 2?
I do, but this is difference in practice, and I don't have any...
And about the auto-transfusion, I only saw it once during my training, and there was a whole mess. So, and then the nurse just connected the line from the pericardium to the vein of the patient. You don't need any additional device or treatment or pump or whatever. You just connect it. Is that correct? I don't remember adequately.
Yes.
You need a male-male connector to be able to do the auto-transfusion. This is the only special device.
If I can make just one more comment on device embolization, we have seen that device embolization, some of them occur the moment you release. So this habit that some of us might have to release and just pull the sheath out of the left atrium is not a good idea. I think we should just stay for 1-2 minutes there just in case, find something to talk about and then get out of the...
One quick
Roberto.
One quick question about the device embolization prevention for the expert. What do you think about the device release criteria? Are enough to prevent all the device embolizations, or do you have in your experience some case where all the criteria were satisfied and then you have the device embolization?
Yeah, I give the word to Jens, but I say only one thing, and we have experienced that with Philippe. You need to be patient and to wait a little bit, because sometimes you have the criteria and it changed during the case. You know, we had a case together that it was a perfect criteria, and suddenly the device changed its shape and it was more proximal. It was about to embolize. So be careful.
Roberto, you can have situations where all release criteria are fulfilled and you still see embolization, that's for sure. But what I wanted to point out is that I really have a long-standing problem with the TOC test because it's very difficult to learn how to explain how to learn the TOC test, and it's extremely variable. Some implanters will really do a vigorous TOC test, some will do a very gentle, some will almost do no TOC test. But we actually did do a systematic study with the amulet device. When you have implanted your lobe and you deploy the disc, you have force on the cable. And you have a lot of force on that device. So the way you deploy the disc for the amulet, you have already done the TOC test. Because if the lobe stays in the same site during disc deployment, it's a stable device. And for me, it's unlogical. Then you try again to make force on the device, and you can make trauma to the wall of the LAA, and you can get effusion, and you might also get an unstable device. So I only do TOC tests if I'm really in doubt if this is a mechanical stable device or not. I think it's a very difficult part of the procedure to do that, or should we rely on? We can. Are you not doing TOC tests only with amulet or also with Watchman? I'm doing it with the Watchman, but I must admit it's extremely rare that you have an unstable device with a flex when you do the TOC test. And if you have the signs of good compression and you have measured and that you have 20% compression and the device in an optimal place, I mean, do it add really more benefit? I don't think so.
Why do you say that when you are not releasing the disc, you are pulling a lot? Why do you know that the disc is, the lobe is stable?
Yeah, I can see on fluoro whether the lobe. Yeah, you are pulling a lot in the device. What we did put a force transducer on the cable and measured the force when we deploy the disc. You have a pulling force on the cable. That's the way you should deploy it. Otherwise, you don't get the disc up to the pulmonary vein ridge.
Yeah, Erik, sorry. The problem is that when the lobe is in place, especially in a patient with a sinus rhythm, a few heartbeats might change its shape and its position. So the moment that you deploy the disc is not exactly the same situation when of the final, implant. So sometimes the additional tag test might make the device shift a little, might even make the device embolize. And so I'm in favor of a small tag test for all cases. All small. Yeah, I will tell you. We used to talk about the American football, the shape, not the basketball, for the shape of the disc. Now I think that this football is a little deflated. It's less. But a little tension has no harm, and at least on my experience, I think it can prevent embolization, because we have done it a few times, and then the device embolizes on your cable. So I'd rather have it, connected and implant again instead of,
I think
but again, this is an everlasting.
I think we can say just to merge what you both said is that we should avoid an aggressive tug test, which has no reason to do that, because actually, even if you have a device nicely placed, you just destabilize everything. But as you said, Apostolos, sometimes a light tug test can unmask an unstable device, and I think I agree with you. So it's a consensus. Who does a tug test for each case at the end of the procedure?
A gentle. We have to define what is a gentle.
Yeah, avoid aggressive tug tests, because you destabilize the device. Sure, I agree. Okay, so I don't know. We have still time, Xavier? Or? No. I don't see the timer. So thank you very much to all the speakers. Thank you so much.
Okay, we are now coming to a very important topic, because before the meeting we asked you to prepare some research proposals to discuss in the context of the potential registry, but also in the context that we are a lot of specialists here and we have an extreme nicely opportunity to make collaborations and make contacts. So I want to call upon all of you that gave some proposals, but there is 15 proposals, so I cannot give you more than few minutes to present. You have one slide with all essential information, and then you can present your ID. And then everyone that is interested can contact you, and all participants here will, at the end of the meeting or after the meeting, have an overview of all the proposals. So in that way, I think we can establish those collaborations. So the first proposal is related to the optimal transeptal puncture site, and Lisbeth had to catch a flight earlier. But the idea with this project is really, we have during this meeting talked a lot about can we with cardiac CT predict what is the optimal transeptal puncture site, and we have seen all the different types of software and what people do I think what Lisbeth wants to test, does it really have impact that we do all those things? Can we really do it and create an optimal transeptal puncture site? So if you are more interested in testing this out, the hypothesis here is not totally clear in the design, but the overall idea is to closer evaluate whether we really can achieve something with our pre-planning of the transeptal puncture site. So that is Lisbeth from Belgium that would like to go into this.
Sorry, Erik. So all the participants then will receive, an email with all the proposals and all the contact mail. So if you are interested, I mean, you don't have to write, you will get it, no? So then they can decide if, that study fits, with the interest of the center, and they can recontact.
So Einas from Latvia, can you please come here and elaborate on your proposal here related to guiding LAAC either by TE or ICE?
Okay, thank you first of all, thank you for inviting me to this brilliant meeting, and for those who are still remaining here. Yes, this is, I think we had a lot of discussion about our own experience, and this is individual experience, and I think if we go forward, we need also some stronger evidence, like, and usually it's based on randomized clinical trials. I think one of those issues is which modality is the best for the procedure guidance. We can tailor in every site different techniques, but if we want to implement and to provide to a wide range of the implanters, and if we want to expand, involve more sites across Europe and globe, then we need more stronger evidence about
it. Should be centers with high experience with ICE then.
Sorry?
That's for this trial. Like it should be centers with highly experienced in ICE, just to make this randomization. So it cannot be offered to all the centers, no?
Yes, not all, but who are doing both. For example, we have available both technologies, but as my experience is still limited for using ICE, but I would be happy to get more experience and also data. Because if you speak about expanding procedure for wider range of people, then definitely I know in my center I have limitation using TE, and then I need anesthesiology staff, echocardiographers. So definitely I cannot increase my number of procedures, but in future, I think the future is based very much on ICE-guided procedures.
I think it's a great proposal, but I think we should think about modifying the design. I'm not sure the randomized clinical trial is clearly adapted for that. 2 examples. I don't do ICE, but I can recruit patients with TE, for example. And that would be, for some events, something completely acceptable. I'm not sure that Jens Erik or Ole would go back to TEE for such kind of trials. This is another pitfall.
Yeah.
So the idea, of course, is brilliant, and we want to show at the end that it's not inferior, but maybe another design would be acceptable.
Beyond the randomized trial, because as Xavier said, you need to have the same level of experience in both groups. If not, you create a bias. Yeah, something prospective, comparing 2 different settings of experienced operators using one specialized in ICE and one, and have clear outcomes like what is procedural time, what is recovery, cath lab workflow, and very specific and cost economic analysis, which is difficult because if you compare different countries, it's difficult. But that's a great question. How do we do that? Randomized or comparison prospective? Because at the time being, we have only sub-study different comparison, which are retrospective or not really, not very clear in terms. If you want to expand it, you
maybe matching patients, no? Could be a good idea. Matching.
Or matching, yeah.
Hello. Think about the design, extremely relevant issue, and but you have to go home, contact Einer's think about the optimal design? Sorry, we have no more time. So Morten or Carl?
May I have a short comment?
Yeah, okay.
For the design, it's a statistical method. It's a cluster method. There's two different centers, and then if you do it in propensity sport, then it should be matched.
Good idea. What about Morten or Carl? Are they still? Yeah. So please come and present about increased sensitivity for diagnosis of PDLs. That's important.
So good afternoon or good evening. The project that we are launching and the study that we will be doing the next coming months is actually to determine what the best follow-up is after implantation of a Watchman device. As we heard today and yesterday, TOE is most available in most of the centers. We also know that CT follow-up might not always correlate with outcome. And we also know that residual leaks are very important to have a good result. So the idea is to have a new modality to identify residual leaks, peri-device leaks, after LAO implantation with Watchman. And so we would use echo contrast sonoview to see if it's better to identify residual leaks after Watchman implantation. We would do it during the implantation, so at the end of the procedure, and we would do it at 90 days and then compare it with CT to see what the sensitivity is to detect peri-device leaks with CT, because then we may be lower and we might have the result that it's not necessary to do CT follow-up, and maybe we can just identify residual leaks with the contrast echo, and then we know that these patients have to be followed up closer. So the design is already modified a little bit. We started with a randomized study, but now we changed the design to a prospective cohort study because we actually don't need to randomize. We need about 175 patients to have adequate power. It's only Watchman, and you would need to have both CT and echo and contrast echo available in your lab. And we need to have 15 frames per second fluoroscopy, but everybody has that. So if you're interested.
Can I ask you, which contrast agent are you using?
Yeah, it's sonoview.
Sonoview, and will sonoview pass through the membrane of, for example, a Watchman Flex device?
Yes, it does. So we tested it. So actually the protocol is ready. So we tested it. You can nicely see it. And there's even more interesting points in the study. For example, we saw that patients who are continuing DOAC treatment on top of their LAA closure, the patency is even increased with sonoview. So I think this could yield some very interesting results.
Apostolos.
One question and one comment. Having the CT as gold standard is a problem because it doesn't show leaks, it shows patency.
Yeah.
So you need to combine the presence of contrast in the distal part in combination with some kind of tunnel, which makes, but theoretically, this patency clinically relevant. One. And the second is, the question, you try to, so instead of using color, you will use sonoview to show communication. And why don't you randomize?
Sorry?
Why don't you randomize?
Because then we would need a double amount of patients. And we have actually a regular echo with color Doppler, and then after that you just inject the contrast. So you can do both tests in the same patient, then you need half amount of patients. So we only need 175 or 200 patients to see a difference. There was an option, but we decided not to do that, to have it blind. So that meant that the sonoview echo guy would not know what the color Doppler echo guy saw, but that's irrelevant if you look at the echo.
And what is the final aim to show that it's the same?
Yeah, so the idea is the study is powered to show that with sonoview you are better at identifying residual leak 90 days, not 45, but 90 days after Watchman implant. But the most interesting will be if after the implant, immediately the same day, so at the end of the procedure, if you give sonoview and you see more residual leak, that then 90 days later that residual leak or peri-device leak is still there. So that you upfront know that this patient will have leak at 90 days. And that way, you may change, but that's not, the study is not powered for that, but that way, in the future, we might be able to use SonoView to see which patient need dual antiplatelet, single antiplatelet, low-dose DOAC. That's actually the idea. But that's already a step further. Just to have it streamlined, because otherwise there will be too many confounding factors.
You know, if you have a SonoView crossing through the membrane, then this is not a leak.
Agree, but you also can see around.
So you need to have some clinically relevant observation. So I'm not sure whether this design will end up in something very useful.
Yeah, thank you for the suggestions.
But after 90 days, will you still see SonoView passing through the membrane, or will you see full sealing?
Yeah, that's the question. We now did it after 45 days, but then that's why we want to do it at 90 days, because we still see it at 45 days.
Because actually it could be a very, very interesting test if we have full endothelial coverage of the device. It could be a new marker for that. So I think it's extremely interesting. Thank you.
And Martin, you want to do it single center, or you want? Yeah. Okay. I mean, the fact that you detect more leak, whatever it is, intra-device leak, because also with CT we have defined intra-device leak. So I mean, it's the same. You can fill the gap with TE and CT because Erik has shown that when you have compared TE with CT, that you detect in the same patient you detect more leaks. And more patency, sorry, when the T says that you have nothing. Then I have that in my experience a lot, that the T says it's perfect, and the CT shows patency. So that also it's a pilot trial, it's descriptive, but it's interesting.
Luigi, are you in the, come please to the podium and explain us about fusion imaging to guide LAAC and your project thoughts here.
Thank you very much. I propose the implementation on large scale of fusion on the CT. We use a pre-procedural CT as a standard of care in our institution, and eyes for intraprocedural guidance. And I'd like to evaluate whether the adjunctive use of fusion on the fluoroscopy with the CT imaging, with the pre-procedural CT imaging, may give a procedural advantage in terms of less procedural time, contrast use, device repositionings, complications, leak, and so on, and the outcome. And this may be a prospective registry in a large scale of our standard procedures.
So what kind of fusion do you need? Just for the equipment, in terms of equipment, so it's
a fusion between the pre-procedural CT and the fluoroscopy with the intraprocedural eyes as adjunctive tool. So this
no, but I mean, it's like it can be done with all, like Philippe, GE, like Emol.
We have GE.
Do you know if, no, because I mean, for the people that might be interested, if it's only with GE, it can also be done with Philippe, or?
We now have a limited experience on GE with the CT and the fluoroscopy fusion.
But this kind of fusion, CT and fluoroscopy fusion, works well with Philips and with GE and with Siemens and with many systems, so I think you should include. What you can think about is to add another comparison is CT plus TEE versus CT fusion plus TEE. Then I will give you 400 and more patients. We are doing like that. We have the data of these patients.
So then a third group, no? It's...
Yeah. Eyes, I mean, that's great to have eyes and see if the fusion adds something more. But we can think about the same design with TE.
Yeah.
Because otherwise it makes, like really specific, and it might be difficult to find.
You might be the only one to use this. So if you want to open to other sites.
And why didn't you consider 2 prospective cohorts? Because this comparison with historical data is always a little bit problematic. So couldn't you just have 1 cohort without fusion and 1 with fusion?
Also, yeah. It's randomized, sort of randomized trial, yeah.
Okay, please stay, because I know you have more very interesting.
Let's see here, Luigi. We have you on the podium now, so
this is also a very interesting problem. We have been talking about how can we maybe benefit coronary artery disease patients that require a lot of antithrombotic treatment by offering LAAC to those that have AF at the same time. So explain here.
My idea is for patients with a very high ischemic risk after a complex coronary PCI, namely more than 3 stents, long treated vessel, or longest vessel segment treated, or left main or proximal LAD, so complex PCI that need for dual antiplatelet therapy and that need at the same time for oral anticoagulation with an high bleeding risk. And so the idea will be the comparison between 2 strategies, LAAC plus dual antiplatelet therapy prolonged for 3 months, or short dual antiplatelet therapy plus standard oral anticoagulation. I think that a randomized trial between these 2 different populations may give us an additional big population where we can implement left atrial appendage occlusion strategy. Patients that have high bleeding risk, not contraindication to oral anticoagulation, but a relative contraindication to oral anticoagulation.
I think this topic is really important. We all know that there are ongoing trials on that. High bleeding risk patients are patients we are treating with LAAC. DAPT could be also SAPT, could be OAC, low dose, and different regimen of antithrombotic. This could be embedded in the registry, Jens-Erik. I don't know what you think about, but we can match patients and see if SAPT is as safe as DAPT or OAC for prevention of thromboembolic events or DRT or something like that.
No, but it makes a lot of sense. I don't know if there is any ongoing trial like this, but it's just a patient that comes to the cath lab, PCI, has atrial fibrillation, so he's probably on anticoagulant. So since the patient is going to need antiplateletations, so we close the appendage and we just give DAPT, that it's going to be good for the stents as well, or we just give following the guidelines, we give like this 1 month triple therapy and then, like the clopidogrel plus DOAC for 1 year. So I think that it's very relevant, but I don't know if there is any trial.
The WOOST-3 trial is currently doing DAPT in patients with indication for OAC, and it's just 1 month DAPT without LAA closure and without oral anticoagulant. So, and they're randomizing between.
So sorry, can you say it again? Sorry?
The WOOST-3 trial.
So what are the...
So it's just patients ignoring PCI with an indication for NOAC, and they are randomized to 1 month DAPT without DOAC versus DOAC plus clopidogrel, for example. So it's basically the same as yours, but they don't close the LAA.
And the group with DAPT, they don't receive
nothing.
DOAC?
1 month, nothing. Yeah.
During 1 month, and then after
1 month, and then after 1 month they restart oral anticoagulant, and then the investigator or the operator can decide if he continues aspirin or what he does with the other
and
antiplatelets.
They stop the aspirin, and they just...
After 1 month they can choose, yeah.
But it's a PCI patient, so well...
Yeah. So I think it's a very good idea, but I think it's a very big study that you need to have adequately powered, and you need support from industry if you really want to do it randomized. And isn't there any risk for slow enrollment in such a 500 plus patients? So, but it's, yeah, if it's doable, then it's great.
The number probably depends from the risk of bleeding of the starting population.
Nina, you had a question.
What exactly is the time frame in between your PCI and the closure of the left atrial appendage?
I think in the same hospital stay, so the day after, 2 days after.
So this
after,
might be
after a complex PCI for very old people with an STEMI. I think this is the clinical situation that we commonly encounter in our clinical practice, and that we propose this alternative route to.
Yeah, then this becomes maybe more important because you need support. So this might be not reimbursed by all the countries, for example, in Germany.
But it's for me super relevant because those patients might need another PCI, if you already have. So at the end, the patient gets rid of the anticoagulant, so he can go on with DAB. So I think it's very good, but it needs of course, support from the industry. That's for sure because it's a big trial.
Luigi will say a little bit more. So productive.
Last idea was to evaluate the combine of mitral edge-to-edge valvuloplasty plus left atrial appendage closure versus standard edge-to-edge plus oral anticoagulation in AF patient with an high bleeding risk, hypothesize a NAS bled higher than 4, and to evaluate whether, randomized fashion, whether on 1 year follow-up the outcome of bleeding events is lower in patients that underwent mitral valvuloplasty plus left atrial appendage occlusion versus patients that remained on oral anticoagulant therapy. So this is another.
I have a question about that. Do you will associate LA closure and mitral clip in the same procedure?
Yeah.
And you will repeat the transeptal puncture in another location or using the same sheet, or did you think about that?
It depends. It depends from likely from how difficult may be the left atrial appendage occlusion in that specific case. But in our experience that I think it's about 20 cases of a combined procedure, we usually did not repeat the transeptal puncture, but we used the transeptal puncture that was used for mitral.
Yeah, I think that the population and target population is very interesting, but the only one question, are you able to Italy reimburse these two procedures at one time? Mitral clip with LAO?
From an economic point of view?
Yeah.
Oh.
Yeah, because it's mitral clip plus LAO.
Depends.
I strongly believe that without the industry support for the device, it's impossible. Yeah, because it's until the price of the mitral clip, you should add something for the device. If it will be not at the same procedure, it's easier. But during the same procedure and during the same hospital stay, at least in Poland, I don't know how in Germany, it's impossible. Yeah.
And have you screened the percentage of patients that will fit this inclusion criteria? I mean, for mitral clip, like 30–40% have atrial fibrillation, or even more, like almost 50. But then from those 50, how many would have a Hasbled of more than 4? Have you explored that, or?
In my opinion, it's a very, very prevalent population for the use of mitral clip that we have now in the Italian situation.
Mitral clip plus Hasbled more than 4.
Yeah.
Hasbled more than 4, it's quite a bit.
I don't think Hasbled 5 or higher is possible. I mean, Hasbled 5 or higher, or almost no one is on warfarin anymore, so you lose label ANR. Everyone should have controlled hypertension, so you lose uncontrolled hypertension, and then you need either extremely severe kidney disease or liver disease. So I think Hasbet of 5 or higher, that's almost, well, that's very unprevalent, I would say.
I think it's very ambitious, but I don't know if there is enough, in terms of, I would say, ethical committee and things, is there enough proof to say that it's a safe combination, do a mitral clip and LA closure? I don't know exactly the literature about that, but I'm not sure there's a lot of paper and a lot of...
about safety?
No, first, I think first before going to a randomized trial, first show that it's technically feasible, it's relatively safe, and then you can go for a randomized trial. That, because to my knowledge... I mean,
we have actually, Laura, I mean, if you want to explain that.
Thank you very much.
We review our series, and to use the same transeptal puncture, it ends that the device, the left atrial appendage closure device, ends in a worse position than when you do a dedicated transeptal puncture. We review our series and we already published it. And the other thing is that I'm concerned regarding that you make some stenosis with the mitral clip, and so you have more susceptibility for thrombosis in the atrium. So it's like maybe it's not like a stenotic mitral valve like in rheumatic disease, but you also may have more thrombus than in patients without mitral clip. So in patients without bleeding and with a clear indication for closure, I think there are too many things that can be risky in this kind of study.
So some kind of feasibility, safety, serious before maybe going to a randomized clinical trial would be wanted, I think, yeah. Roberto, can we have you here on the podium to discuss this study here, which I believe is something that we can use an upcoming registry for, so please.
So, thank you for this great opportunity. Yes, our idea was to started with the comment we did before. We are not sure if the hypothesis that the current device release criteria are not adequate to prevent the device embolization. And so we would like to investigate retrospectively this kind of events. And how? We would like to invite all the participating centers to share with us their cases, clinical data, and periprocedural images of TE and angiography. And then with a central assessment of the images, we would like to carefully assess, test the device criteria release, and some additional parameters to see if we manage to find some predictor of device embolization. Of course, we are going to ask also some control cases. So for each device embolization case, we will ask 2 control cases matched in terms of device used and temporally adjacent performance.
Do you also plan to report on the management of the embolizations? I mean, how they were captured, if not, you know, the outcome, or just only focus on this?
I think in terms of management, we have enough data available, so we are going to focus more in prediction. But
what I like very much is because when we look all the literature about embolization, it's the mechanism is self-reported. Huh? So if you can collect images and understand really what happened, because sometimes people say, everything was perfect, and actually when you look at the images, it was not so perfect, and it was, I mean, all the implantation criteria were not so good. So that would be nice, and then you could really see what is the main mechanism,
yes,
or different one.
And we would like actually to see if these parameters that are qualitative transform them in quantitative assessment. Because maybe some criteria are described like a position to the wall, but in which view? Should be opposed to the wall in all the 4 views of TE, or is enough just a 2 view, and if we have a bit of protrusion in the other 2 views is acceptable? Let's see retrospectively if we manage to give an answer to this question.
No, I agree. It's a great design and great idea. You should collect the maximum information that you can get, especially the pre-planning CT or 3D TE, because as you mentioned, we say, okay, it was not, the compression was not good, but we don't know in which angulation you're looking to that. So collect the maximum data before the implantation, during the procedure, and then it will be, if with a centralized collab or examination of technique, of procedural techniques and findings, that would be great.
Just short.
A good question. We thought originally to Amulet and Watchman, but then based on the data we receive and the participating centers, we are going to maybe modify this cohort. Just one quick question for the audience. How many of you would have...
Yeah.
Sorry.
Yeah, just short comment, and I'm excited about this proposal because really, in my experience, I have had 3 embolizations, and all of them were unexpected because all the criteria were fulfilled, and I'm still not knowing why they embolized. And this is very important, I think, because embolization should be predictable. But if it is not, then we are in danger. Yeah, well, thank you.
Stay, if you agree. Okay. So this is another proposal from you, Roberta, which is really ambitious, but also very important. Give us your thoughts.
Yes, this was an idea of our team because we had problems when 6 years ago we had to design a new prospective trial, and so we based our design on the original paper, the consensus document of Munich. And we found this document now a bit old-fashioned, and we would like a bit to update the definition, to go more in detail in this definition, and to show how to assess all the clinical endpoints and the imaging endpoints, because now it's 7 years that this document was published. Much evidence was published in the last years. And so we would like to give a tool to all the investigators to design their own research prospective studies and to have a reference for them. How to assess a leak, a pre-device leak, in which view, which Doppler velocity use, how to define a hypattonation thickening on the device, how to do that. So give all a tool to be used by investigators.
So, well, you have the first author of the Munich consensus paper that it's... So I don't know, just if you can, it's very difficult at least.
It's mission impossible, I'm telling you right now, but you could think about some kind of amendment of this, you know, some... Not redoing it, because redoing it is impossible, I'm telling you. But you can send an email to us and say there is a request, and I agree with you. We need to update a few things, and maybe we can publish something small, like you know, an extra addition to this. But if you want to redo the document, it's going to. I'm telling you, good luck. It's really very difficult. Mainly because of the endorsement of societies that is lacking.
Thank you very much for the comment, absolutely. We need help from expert people, and it's probably what we are going to do.
Thank you so much for... So there's another subgroup of AF patients with cancer. And that is a difficult group to handle. We have some recommendations for anticoagulation treatment in this category of patients. But Xavier, you can present your thoughts here.
Yeah, well, it was actually more Ignacio than me, but well, you know, like I immediately, you know, supported him. And actually, this is something that it will fit very well with the registry, with the European registry. Anders should add, like a window just about, hematological or, cancer, and then yes or no, and then like define the kind of cancer that the patient has, but it will be relatively easy. So those patients have, prothrombotic status, so we expect in terms of thrombosis and also in terms of bleeding, because they're taking lots of medications, so probably a higher rate of events. So the proposal is to do a retrospective analysis, endorsing and using our registry, and also a prospective randomized study about comparing LAO versus standard treatment that it's NOAC in those patients. Of course, they are like about the mortality of the cancer itself. It's also always, a concern. But I think that in a first step, I think that we should focus the retrospective analysis to define, and then maybe that can be used to power or just to calculate the sample size that we're going to need. And this is something that can be relatively easy, can be done fast. So points of discuss, type of tumors, what do you think?
It just came to my mind because patients with cancer have a high risk for thrombotic events anyway, so they might have a deep brain thrombosis or something like that, which is not infrequent in this type of patient. So, so you might lose a percentage of patients because you have to put them back onto anticoagulation during follow-up.
But well, this is something that can be explored in this retrospective analysis, no? Other thromboembolic events like deep vein thrombosis, and then just to design the randomized or like the prospective study, then it will be like really valuable information.
Yeah, I mean, it's interesting. I've never put a device in a cancer patient, so interesting.
I think one very challenging subgroup of patients are those with myelodysplastic syndrome with a low platelet count. So they have clearly increased bleeding tendency. If they get AF, how to treat them? They will not tolerate DOACs. They bleed a lot on DOACs. And it's also a challenge for us to do a safe procedure in this setting. And my feeling is also that they have some kind of pro-thrombotic tendency. So that might be a subgroup to look more upon in our registries.
For sure, but there's also, patients that I'm getting, those patients, it's not so often, but patients that will get chemotherapy, like very aggressive treatments, and, like hematology is concerned about, like the platelet count and that the patient will not tolerate anticoagulants. So in these patients before, and this is an indication that we've been doing, it would be like high risk of bleeding. So I think
there's maybe two different populations in the cancer population. There's maybe a population with an increased risk of bleeding due to maybe their cancer in the first place, but also due to their ongoing treatment. But I also think there's going to be a challenging finding patients who the prothrombotic condition during a cancer is a systemic condition. And our argument right now for LAO is that this is, we are treating a somewhat local problem with a local treatment, right? So I think maybe this would need an LAO plus some kind of anticoagulant versus standard treatment in these cancer patients, at least for the maybe non-hematological cancers.
Let's explore it. I mean, we have the information, so I mean, and then answer from like the registry, I think.
At least start with an observational study, which is really great to describe the events in this kind of population. We don't have this anywhere. We have subgroups in trials that we all know, but a prospective random registry with this kind of patients and explore the events, it's really great idea.
Yeah, thank you, Xavier. So, Claude, you want to evaluate period device leaks with either CT and compare with TE evaluation. Can you elaborate on your thoughts and design? Come to the podium and explain what you want to do in this trial here.
Yeah, I mean, the idea just to try to, fill the gap that concerning the evaluation of leaks after the implantation. So try just to investigate if CT is superior TE. We might envision a randomized clinical trial, or even the same patient could be just, the control of himself. I mean, just so there are two proposals. I think that it's quite feasible because everybody, does TE or CT, and even though we at the very beginning we thought a randomized clinical trial just with two different group. And with the control at 3 and actually 3 months after the implantation and at 12 months. So this is just roughly the idea. So I think that even in the literature we don't have a really clear-cut idea concerning the occurrence of leaks and a very debatable issue. I mean, this is.
Can I just comment on that? We just published this meta-analysis in European Heart Journal. I don't know if you had the chance to see, and it's clear that the leaks that were detected by CT did not predict outcomes. So, and whereas the leaks that were detected on TE, there was a prediction of outcomes depending on the size of the leak. And the cutoff of statistical significance was 3 millimeters.
Yeah.
So it can be, of course, this is retrospective meta-analysis, lots of statistics. It can be a matter of, randomization, but I think before doing that, the most important part, and consensus is really needed on that part, is on the definition of what we're talking about. And Erik has worked on that, and maybe you can comment. Maybe that's an idea I had, to combine the patency to get on CT with some communication that should be shown, like a channel. I think this is the first step, and then move a step forward and do what is clinically relevant for sure. I mean, I totally agree.
And thank you. Also, I think that we have different data in relation to different devices, because sometimes there are doubts, what happened maybe with the amulet. Even in my institution, sometimes I have some, feedback that there's a leak, and then the echo guys, tell me, no, there's no leak. So I think that even in relation to the different devices, I think that we can get different information and different feedback. Yeah.
I think, as Apostolos has said, I think we have enough, I would say, data to show that a leak on TE with the new cutoff now of 3 millimeters has a prognostic importance. But what the CT can bring on top of that, probably not in a comparison, but it's about the mechanism. It's about the mechanism, and I agree also that a way to assess the mechanism plus severity and see what kind of mechanism, because it's a very frequent finding on CT that you have leak and so on. So we need something to link some of the mechanism of leak or intra-device or pre-device or uncovered lobe, whatever, to the outcome. What is dangerous? When you see patency on CT, which one is dangerous? And that's a problem. It's so frequent that it's actually, you cannot sort anything for it.
We definitely need more information about, contrast patency diagnosed by CT. If there's no visual gap, is that a harmful phenomenon? Your analysis, Apostolos, seems to suggest that this is without any harm. On the other hand, I think CT is in the future the preferred follow-up method for those patients, and we just have to learn how to quantify the leaks with CT. We have to agree on should we measure the actual diameter of a gap, should we measure the area of the gap relative to the total area of the device. There's a lot of research still to do to understand the clinical impact of leaks, and I totally agree that the mechanism of a leak might, it will of course be dependent also and make an impact on the prognosis, because a full missed lobe, for instance, that might be much worse than just a 1 millimeter leak or something like that. So I think we have a lot more to learn. So if we can do systematic studies like this, I think that would be very, very helpful.
Yeah. This also should be captured in the registry. I mean, if you do follow-up.
Yeah, it's not, yeah.
No, but just we don't want to randomize. We want to prospectively see the impact of different leaks on the outcome, and you have to start with that. I mean,
I also think for this particular purpose, you don't need to randomize, right? Let the patient be his own control. I think that's most reliable, and also you can gather TE and CT in the same patient, and then correlate. If the outcomes on TE correlate with clinical outcomes, you can find out which parameters on CT correlate with the TE, and then maybe in an indirect way with clinical outcome.
Okay. Yeah. One question to Anders. In the database, in the REDCap database, the leaks of the amulet device can be counted in the disc and also in the lobe. Is it possible to make that differentiation, or not? Because if not, I think that, because I don't know, like when we have an amulet, if we should measure it at the disc, at the lobe, or both, what counts more, the lobe, the disc? So is it possible to have this? Well, but if you see Doppler in the disc in amulet, you can. Yeah, but then we measure. It means that we measure it at the disc, no? So. Yeah, and the question is, in efficient study, is it only that we document there is a leak? This might be possible, but if we have to look and quantify the leak, so then we need to look at the extension. This is even more difficult if we have a leak around the lobe, because then we have to cut down to the leak and to really measure. No, but if you have a look at it's very good, the database, because you have all these options, superior, inferior, so I check, the paravalvular or device leak, but maybe it would be interesting to, if possible, to make that difference, no? Yeah. I mean, definitely, because I think the size of the leak will matter, and it's not just patency. But that variable is there, so it's good. Yeah. No, yeah, I know. But
it's there for CT as well, Anders. Can you confirm?
Yes. Yeah. And of course, it is possible to, at least for CT, you would be able to divide it out into disc and lobe leaks. But again, I think we're coming back to what Roberto was alluding to before, that then we need to have some kind of streamlined definition of what is a PDL is it on either on TE or on CT. So you will get some heterogeneity in the reporting.
Yeah. I'm sorry, but we have to stop the discussion. Thank you, Claudio. Thank you. Because Sandra, can you come and explain us about this idea here, which I think is also really relevant?
Good evening, everyone. So we wanted to present one project about treatment after left atrial appendage closure. So in Massy, we have a cohort of patients at very high bleeding risk or active bleeders who cannot have any antithrombotic therapy. And so we have about 120 patients of this kind, and we would like to know if a strategy of no antithrombotic therapy is safe in these very selected patients compared to other strategies. So it would be a retrospective observational study with these very specific patients. So if you have patients like this in your centers, we would be interested.
But you would like to have, a control, no? Like the rest.
Yes, the rest as well.
It fits very well again, with the registry, no?
Yeah, but we tried to engage other centers in this kind of design, but it's not always easy to find centers who are. Yeah, absolutely.
A matching or matching population, and in the registry that's going to be possible because you're going to have lots of
This is data that are available from the ACP registry, by the way.
From the
ACP registry.
But
150 patients.
And actually, when you have like all these registries, you have like the patients that didn't get anything, but at the end, it's like small numbers. So in this registry, it could be like really huge. So that's good.
I like a lot. I mean, just thank you for this proposal, because we have patients who have a absolute contraindication to anticoagulation, like from Willebrand patients or other genetic related disease, and we have this patient without obviously anticoagulation and either anti-platelet drugs as well. So I think that's very interesting. I think this should be just a group of patients considered as a reference. No therapy, and let's see the outcome of this patient. I mean, just in relation to patient who historically or empirically. We treated with the antiplatelet, for the rest of their life. So I think that there's just a way. Maybe it can be related to the fabric of the device, and just in how it's possible just to have patient maybe without any complications in the long run, because they don't have any events. So I think this is a very specific patient population that we need just to take into consideration. So I think that you might be able just to collect, quite a good number of patients.
Yeah, I also think it's a super interesting group, because what should you offer to these patients? On the other hand, I just remember one patient with Morbus Osler, and she couldn't take anything. She was bleeding twice a day out from the nose. And so she got a device. The device was perfectly in place. Everything was nice. And then she developed a DRT. And I really have this patient in front of my mind, because, you couldn't give anything. So you just had to watch how this thrombus was growing. And this was a very frightening situation. So there's really nothing we can offer the patient if we really create something like that. It's super interesting, and I just have this patient in front of my eyes.
Just in one word, we don't want to promote that device without drugs is good for every patient. It's absolutely not the case. Just we want to describe this population because, as you said, we think it's a special population describing all the baseline characteristics and then what happened. This is.
You have participated in a meta-analysis in a publication JACC when they compared the different antithrombotic, and it's known that if you give nothing, you increase the rate. Not like 100%, but there is a higher risk. But sometimes it's impossible to give anything. So it's interesting to see what happens and to what extent.
Yeah, but then we will be able to see those ones that develop DRT. So maybe there is an additional factor, like implantation there.
Absolutely. This is kind of
problem with the meta-analysis.
Kind of lifetime management, of device and drugs and how is the patient at the end.
Yeah, we have to build in the antithrombotic properties in the device, and so we can be totally without. That's the future. So Sandra, please stay, and now you also want to look at leaks over time.
Yes, so another project. We already talked about PDLs, so we would like to evaluate PDLs over time. That is to say, in patients who are already known to have PDLs, because we do routine CT scans in our center at 3 to 6 months. In these patients who already have PDLs, we would like to know what these PDLs become over time and what is their clinical impact, especially for Amulet, because we would use, the idea would be to use the classification of Korsholm that has been published a few years ago. So it would be a retrospective and prospective observational study with Amulet patients who have PDLs on a CT scan, a follow-up CT scan, and then to repeat the CT scan at 12 months to see if some leaks maybe reduce or if it's exactly the same and what are the clinical outcomes.
We do have some data on this, and our group did actually also study this with the Amulet device with the CT follow-up after 12 months, and very recently we did follow very long-term follow-up after 5 years looking at leaks. There might be very few leaks that will reduce in size with time, but the general rule are that they will stay the same, or if you even go to 5 years, they might increase in size, because there will also with time in an AF patient be remodeling of the left atrium, and it will be increasing in size. So unfortunately, I think that the natural history for leaks are not very favorable for spontaneous closure. I think it's the opposite, and for me it's a very good argument that we'll really strive during the implantation to get full sealing. That's the time window we have, I think. But of course, it's relevant to get more data. But
yes, maybe we can hear Roberto, because he has done a Swiss. He was a primary investigator of the Swiss approach trial, and you have a unique opportunity where you have assessed Watchman Flex, mostly Flex versus Amulet, and you have 45 days and 1 year follow-ups. Can you elaborate?
Yes, exactly. It's one of the sub-analyses that will come soon. We are going to assess the leak at 45 days and which are the morphological aspects of this peri-device leak that predict the closure at 1 year and which one predict the persistence of this peri-device leak from 45 days at 1 year. That are probably the most dangerous, because we know from the literature that the leaks at 1 year are the most clinically relevant. So those who persist at 1 year should be maybe considered more and maybe closed percutaneously.
I think also in Predict LA we had also a 1 year follow-up CT. I don't have yet the result, but there was a 1 year follow-up CT. No, 3 months and 1 year. No,
I don't think we have probably 12 months.
Not for all patients.
Okay, but interesting.
Thank you, Sandra. One proposal that I have is related to this practical clinical problem of patients with an LAA device coming with AF and with a need of electric cardioversion. So how can we do that in a safe way, and how can we build an algorithm that we can use, all of us? We have an algorithm in our own institution that we actually do pre-imaging in those patients. We will do either a TE or CT scan if that is more convenient in the given situation, in order to evaluate, is there a leak or is there something on the device? And if we don't encounter a problem, we just convert without any pre-procedural antithrombotic therapy, and we also avoid to put the patient back on more intensive antithrombotic treatment. But I mean, this is just empiric data, and I think we need to, in the first round, ask the European sites, how are you handling those patients? Are you doing TE? Are you giving them low molecular heparin, or what are you doing? How are you handling those patients? So I would like to have some kind of European survey on how we handle this problem with DC cardioversion and an implanted LAAC device. And at the same time, I think it will be relevant to capture data and look at their thromboembolic events 3 months after DC conversion to look for, do we really have any issues with stroke, TIA, or thromboembolic complications? So, and I think that is some of those questions can also be answered within a registry. But so, do you all of you, do you have specific algorithms for doing this, or are you taking a lot of telephone calls about how should I handle this patient here? You gave this patient a device 3 days ago, and what shall I do? I mean, that's practical.
Yeah, with us it's extremely rare because many of the patients are elderly and sick and they have persistent permanent AF, so we don't do many cardioversions in these patients. But maybe in the future, if the number of LAAs goes up, maybe it will become relevant. That being said, even in patients with a very low CHA2DS2-VASc score, 50 years old, you temporarily anticoagulate them after a cardioversion. So maybe intuitively, if it would be necessary, I would give them a very short duration of something after a cardioversion. But I've actually not encountered it yet because we don't cardiovert many of our LAA patients.
I think we have very few data on this, so that's definitely something we can improve.
Yes, there are a few data, but what it happens to us, just patient who already had ablation for AF and plus appendage closure, they can come back to you with recurrences. So and then maybe just they are just on aspirin for the closure. If they have just 2 or 3 days, usually we don't do anything. We cardiovert the patient. Otherwise, I mean, just I agree just to give the heparin just for a short period of time, and then. But probably, I mean, I have patients, but patients who already had a previous catheter ablation for AF plus appendage closure. Yeah.
Thank you, Claudio. Okay, I think that was the last proposal, so we are going to try to wrap up this whole
Jan, just, I know that it's late, everybody's tired. Actually, I mean, it crossed my mind, we might think a observational study, a comparative study using a pre-planning with the TE or CT measurement and, investigate if this measurement really is the same during intraprocedural, measurement with the TE or ICE. I don't know, I mean, just, I don't know the data because usually, I mean, just, I don't see much difference of what I get, the day before with the TE or the CT and the ICE during the procedure. I don't know, I mean, if the same experience of everybody, just because, someone doesn't believe that we need to have a pre-planning. So if this the feeling, I don't know, I mean, just maybe I don't need just to have the measurement before and I can go, directly to implant.
Also another great proposal, but I think we also need some food later this day. So can we have the ELAACC board? We are here already, so why don't we try to wrap up and also take comments from the audience here, because this is the first meeting for us, and of course we have been speculating about all this. Was it relevant to gather you here, to fly you to Barcelona? Is this a relevant forum? Can it bring the field forward? And do we want this again? So it could be very nice for the panel here to hear some immediate comments, I think. And you're also welcome to think over it more, but let's hear some feedback about those 2 days here.
So who wants to start?
Yeah, for me it was very relevant, and the difference between other meetings is that we don't only discuss the technicalities about the procedure, but also just organization, electrophysiologist who does concomitant closure during EP, what are the indications, reimbursement. So that's a big difference between other meetings. So I think it's very relevant. It was, for me personally, I think it's a long day today. We started yesterday afternoon and until tonight 7, so that's pretty exhausting, I think, if I see the audience. So maybe we can optimize that a little bit, but for sure we should, in my opinion, you should for sure repeat it, absolutely.
Joëlle?
Thanks for this initiative. I especially appreciate the interactivity between the audience, the board, everyone. It's a simple meeting with colleagues, experts in that field, and I'm happy to see that it's providing a lot of research and publications and improvement, I hope. So thank you for that.
Yeah, maybe I can add something, because I actually learned a lot, and I learned that I have even more open questions right now than before. So I learned a lot from you, from your experience, and I really like the open atmosphere. So everybody really discussed openly. This is not one of the meetings where you don't say your real opinion. So we heard your opinion, and I really like that.
I think we had some goal together. First, the initiative, I have to say, that came from Philippe, and Philippe has gathered the group and the initiative, and it has taken 1 year to try to find out what was the good concept, how to make a meeting different than the others. Nothing to say about the other meetings, which are good, but we wanted something extremely educative, coming up with consensus, knowing from the audience what they're thinking about many aspects, because we learn a lot from each other, and that was the goal. And this is not always present in all the meetings. Even if there are high-quality meetings, sometimes I mean, the interaction is not as good as we want. We are taking into account what Apostolos has said, because we are very humble, actually. We don't want to take the lead or whatever. We just want to improve the technique, and that's the main goal, I think, of the meeting. But we are open to any suggestion to improve the meeting, to involve more people. So this was most likely, I have to say, a test, which I think was good, actually, and we hope that we can continue, because we really believe that this can bring a lot to the therapy in the future. And that was really the main goal when Philippe invited us at the first time. It was really to improve the therapy and to standardize, although we understand now that you cannot do all the same things, but we can at least come up with some guidelines, whatever is the technique that you use. And also the registry, I think it was a great idea. The classification, the anatomical classification. There's a lot of work to do, but we are open. And as Sergio suggested, that you send to Alexandra and Benjamin from Medi8 event, whatever you think could improve the meeting, I hope, for the next session. That was my word.
No, basically, the objectives, and for me and for the group, but I thought that it was specifically and very important, the registry. So, and that will require an effort from all of us and all of you, but I think if we work and we can get it, it's going to be a very important thing. For the ones that couldn't come yesterday, so we were discussing about the variables. So at some point you will get the invitation, you will get the database for the ones that haven't seen it. But well, I would like to ask now an extra effort for try to implement this, because if we manage to use it and to have this database, it's going to be huge, and it's going to be really a source of research and questions, answers, and everything. So.
For me, I think also the registry and this new classification, it was extremely nice to get a positive feedback. I mean, all of you thought it was a good idea to come up with a new classification, come up with a registry, and we got a lot of very, very good inputs. especially in terms of simplification and things. So we have really now, I think, a platform to make version 2 of both the classification and the registry. And I also believe that there should be a product from a meeting like this, or we are so many people gathered here taking time, so we need to come up with a product. And I mean, if we can come with a European LAAC registry that can go on for many years, if we can really come up with a new classification, I mean, that will be very, very important progress for the field, I think. And why shouldn't we do that? I mean, we have so many good inputs, so I have really enjoyed it. And I would also like to really make a big thank to the sponsors, Boston, Abbott, LifeTech, GE has been a participant, not directly a sponsor, I think, but I hope also the industry can see the potential here, and in the future I could also like engineers in the room, so we could have direct discussion about device technology and modifications and things like that. And I like the room, but I don't like that we are sitting here like some that are more important than you are, because we are not. We should sit at the same level. I think we should make a change for that next year. But yeah, I also really have enjoyed it, and I really hope you share the same thoughts about that. So thank you.
Yes, there.
Thank you. And Philippe, just a comment. Only 1 year ago, when we had the first meeting to create a solid group of experts in LAAC closure, it was a dream. Now this 2 days marathon is a demonstration that is possible, and we should be happy of the result. It has been a great result. I'm happy for that. And I think that we have a lot of potentiality. What Jens-Erik mentioned, to involve in the group the engineers, I suggest expert of imaging, and will be helpful to consolidate the group and to create a really a great cultural reality. It's, I think we should be happy with the result.
Yes, first of all, thank you for being there. The meeting was really great because of a lot of interaction. That's what every people in this room said. We are happy to talk about this, to interact, to hear about this. So I think that was the main goal. The registry and the classification are probably things we are keeping working on, and we will share with you. We will stay in contact, as I said during the welcome. We want to have some kind of community, and we share all this community. We are from away in the same community. And we're trying to increase with imagers. We need more imagers. We need more people from other geographical area in Europe, maybe one day outside Europe, why not? There are people who wants to come from outside Europe. And okay, neurologists, GI, I don't know. We will not do the group of, you know, the open windows, but at least a group that is interested to continue and work and wants to have data and improve the therapy. I mean, the most important for all of us is how the patients are doing after the procedure. And this is what we want to highlight. We don't want to say we are the best. Of course, many people here, we are doing more than 20 procedures per year. But what is the most important for us is that our patients, but also patients elsewhere in other cath labs, are doing well. And if we can help by simple recommendations on simple guidelines, said, okay, in Europe we have seen that this is good, that would be good. That would be good for the patients. So thank you for being there. Thank you for the sponsors, Boston, Abbott, all the teams. We are not able to do that without you. So a great thank you. We are really grateful for you. And again, Alexandra, Benjamin, Mehdi, I thank you for the support and all that you did for the last year.